All right, if you're gearing up for your clinical exams, you can pretty much guarantee this topic is going to show up: hypertensive disorders of pregnancy. So today, we're going to cut right through all the noise and give you a super high-yield guide to preeclampsia and eclampsia, one that you'll actually remember when you're sitting in that exam. Let's jump in.
So here's how we're going to break this down. Think of it like a ladder of severity. We'll start on the ground floor with the basic definition of preeclampsia. Then we'll climb up a rung to see what happens when things get more serious. Then all the way to the top, the big emergency. After that, we'll come back down with the management plan and a rapid-fire review to make sure it all sticks.
First things first, before you can even think about answering an exam question on this, you have got to have the core definition locked down. This is our foundation. Everything else we talk about is going to build right on top of this.
Okay, this might look like a mouthful of text, but seriously, every single word here is pure gold for your exam. Notice the key parts: pregnancy specific. That tells you this isn't the chronic hypertension they've had for years. New onset after 20 weeks. That's a hard and fast rule you just have to memorize. And the most important part? It's not just high blood pressure. It's high blood pressure plus either protein in the urine or signs that the body's organs are starting to struggle.
So when it comes down to it, the classic diagnosis really stands on two pillars. First, you need that new onset hypertension, and the magic number you need to remember is 140/90, or higher of course. Second, you need that proteinuria. You can find it with a big 24-hour urine collection or just a simple dipstick test. If you see both of these things pop up after 20 weeks in someone who was fine before, boom, you've just diagnosed preeclampsia.
All right, so we've got our baseline. Now let's climb the next rung on our ladder. This is where preeclampsia stops being just a concern and turns into a high-risk, genuinely dangerous situation. This is when we start talking about severe features.
Now, this is a really important idea to get your head around. Preeclampsia with severe features is not some new disease. It's the exact same underlying problem, but it's been cranked up to 11. It's the point where the body starts sending out some serious distress signals because major organs are taking a hit.
So what are these distress signals? Well, we're talking about blood pressure that's just soaring, 160/110 or higher. We're seeing the kidneys protest as creatinine levels climb. The liver gets angry with enzymes doubling and that classic right upper quadrant pain. The blood itself changes, platelets start to drop. And it can even affect the brain, causing killer headaches or vision changes, or the lungs, causing them to fill with fluid. And here's the kicker. You don't need all of them. Just one of these is enough to upgrade the diagnosis to preeclampsia with severe features.
Let's just zoom in on this one for a second, because it's a big one. Thrombocytopenia, right? Platelets dropping below 100,000. This is a huge red flag. If you see this lab value on an exam question about a pregnant patient with hypertension, your brain needs to light up with neon signs flashing severe features. It's one of the clearest signs that this disease is escalating fast.
And now, we've reached the top of our ladder. This is the one everybody's afraid of. This isn't just a complication. It's a full-blown, life-threatening medical emergency. Eclampsia.
You know, the definition here is actually super straightforward, and you've got to know it cold. Eclampsia is preeclampsia plus a seizure. That's it. Full stop. It doesn't matter if their blood pressure was sky high or if they had a ton of severe features before. The moment a seizure happens in a patient with preeclampsia, the diagnosis immediately becomes eclampsia.
And let's be crystal clear about this. This is a potential catastrophe. An eclamptic seizure puts the life of both the mother and the baby at immediate risk. It requires a calm, swift, and perfectly executed response from the entire medical team.
Okay, so we know what these conditions are. Now for the million-dollar question, and what really matters for your exams: what do you actually do about it? Because the management plan is completely different depending on where that patient is on our ladder of severity.
The difference in management is like night and day. On one hand, for preeclampsia without any severe features, you can often manage them as an outpatient. Close monitoring, maybe some oral blood pressure meds, and you're aiming to deliver around 37 weeks. But the second one of those severe features appears, the entire game changes. That patient gets admitted to the hospital, period. They're getting IV meds to control their blood pressure, and the big one, the real game changer, they're getting magnesium sulfate to prevent seizures. And delivery? We're not waiting for 37 weeks anymore. We're talking 34 weeks or even earlier if things look unstable.
So what if the worst actually happens? What if she has a seizure? This is your emergency playbook. Your absolute #1 priority is stabilizing the mother. So, step 1, you protect her airway. Get her on her side, give her oxygen.
Step 2, you give magnesium sulfate to break the seizure and prevent more. Step 3, you get that dangerously high blood pressure under control with IV meds. You monitor everything closely. And only then, after the mother is stable, do you move on to the final cure, which is step 5, delivery. Remember the mantra, stabilize mom first, deliver second, always.
Okay, let's pull all of this together. If you're going to memorize just one thing from our entire chat today, make it this next slide. This is your ultimate cheat sheet for your exams.
This table is your best friend. Look how simple this makes it. You can tell everything apart in a single glance. It's all about what gets added. You start with just high blood pressure. No protein? That's gestational hypertension. Now add protein to that? Boom, you've got preeclampsia. Now either crank up the blood pressure to 160/110 or add any of those signs of organ damage. Now it's preeclampsia with severe features. And finally, if a seizure happens at any point in that preeclampsia journey, that's eclampsia. Mastering this simple progression is going to help you crush almost any question they throw at you.
So I'm going to leave you with a question that doesn't have a simple, multiple-choice answer. We've said it over and over. Delivery is the cure. But what do you do when the mother is critically ill, but the baby is so premature it likely won't survive outside the womb? That's the ethical tightrope we walk. And that's where the textbook stops and the real, messy, human side of medicine truly begins. Something to think about.